I want to talk about reasons why I think we want to prepare ourselves for life beyond the age of 65. And yes, there is a life beyond the age of 65, as you all know. And I want to talk about some of the strategies you might consider for successful aging. Things you probably already know, things you may not know, things that may surprise you. We'll see. Next slide. So, Jane Austen was a successful aging woman. She outlived her sisters. She outlived friends. She outlived cousins. Do you want to know why? Next slide. She died at 42 but she outlived them all because she had no children. She remained a spinster. So the secret in the 19th century of longevity for a woman was not to marry. Next slide. What about in the 21st century? Jeanne Calment was the oldest living woman in the world. She lived to 122. Now, she smoked, she drank, and she didn't purposefully exercise. So what did she do? Next slide. Well, at the age of 85, that was in 1960, she took up fencing. And I don't mean she built fences, she actually fenced. She was riding a bicycle up to her 100th birthday. As I said, she wasn't athletic. She had a great retirement plan. In the mid-50s, in France, they had a system where it's sort of like a reverse mortgage, where you would sell your apartment or house, and then you would live in it. And the person would pay you a sum every month, like rent. And the idea was, when you died, they took over. So she did it at 55. So at the age of 117, the great-great-grandson of the person who had bought it was trying to get possession of this apartment. So it was a great retirement plan for her in terms of a pension. She continued to be active really up to, unfortunately, she fell and fractured her femur. And that happened at the age of 114. But as I said, she still continued to live for another 8 years and enjoyed a lot of notoriety because she was discovered to be the oldest living woman who still remembered meeting Vincent van Gogh at his 100th year centenary. Next slide.
And where did she live?
In Paris, France. It must have been the red wine.
The cold ones.
This slide is a really common slide you'll see in a lot of the literature. It really talks to the fact that life expectancy has been increasing for the last 100 years. Between the period of 1910 and about 2000, we roughly increased our life expectancy 1 year every 10. What was interesting was that around about 1995 to 2005, it looked like it had plateaued. In other words, we thought we'd achieved the benefit. But in fact, in the last 10 years, it's taken off again. And actually, it's accelerating. Next slide. Now, the reason why we talk about life expectancy is this idea of changing population and the big impact, of course, of the baby boomer group. So traditionally, we've talked about the group between the ages of 15 and 64 as the group who produce, and the ages between 0 and 15 and 65 and older as the dependents. Now, I think many in the room will challenge that designation. But traditionally, there's been a certain ratio of producers to dependents. And the concern has been that the trend, of course, with an older population is that there's more people over 65 and fewer people under 15. We were happy when there were more people under the age of 15 because of the assumption that's going to generate more producers. Well, the good news, of course, as we know around the table, many of you are active and still producing. So we don't stop producing at 65. So this concern about the dependent to producer ratio isn't as big as we should think. Next slide. What's the new norm? Very old are becoming common. Next slide. So in the 2011 census, there was nearly 6,000 people over the age of 100. Sounds impressive, doesn't it? Particularly when you look back and saw that in 2006 it was 4.5, and in 2001 it was 3,800. What do you think is going to happen in the next 20, 30 years?
Sorry, I stole your thunder.
Oh, you terror. By the year 2050, there will be 50,000 people in Canada over the age of 100. Every child at this moment in time under the age of 10 has a 50% chance of living to 50 if they avoid obesity and inactivity. Next slide. The oldest baby boomer, who's 66 this year, can expect to live at least 17 to 20 years in retirement if they retired at the age of 65. Next slide. Do you think they financially prepared themselves for that? Okay, that's a rhetorical question. Next slide. So, changing expectations and realities. Next slide. Baby boomers. We know this group that have really influenced tremendously Canadian society. They're the reasons why we had Toys for Us, the expansion in schools, the expansion in things like squash courts, the reason why now golf is becoming even more popular. So this group of individuals have had major influences, and now they're retiring or reaching retirement, or they have older parents. So they've actually changed a lot already, the expectations on Canadian society, and will continue as we move through the next 10, 20 years. Next slide. Now, here's the bone of contention. 1 year per decade addition, I mentioned it started to rise. There's actually some evidence that starts to suggest, but because of some new technologies and new improvements in health, if they're properly applied, that actually life expectancy may increase by as much as 30 to 40 years by the year 2050. So that 50,000 people over 100, many of them may expect to actually live at least as long as Jean Calment, and perhaps longer. So we may have a new record by the year 250. So baby boomers may have to actually start thinking about not a 15 to 20 years plan for retirement, maybe 40 to 50 years. Wouldn't that be awful? Next slide. So, why prepare for being over the age of 65? Next slide. Well, I think many people in this room want to have some control. You've probably been used to having control. You're not going to give up easily and go where perhaps your family tell you, off to the old people's home at a certain age. No, it's not for us. Next slide. We need to realize that actually we're already seeing this increased life expectancy, and it's going to increase, almost certainly. So you need to realize that you have to leverage what you need to do for what will actually be at least 25% of your life, the period after 65. Next slide. We all want to have a satisfying retirement. Next slide. And of course, we all learn from people who came before us, don't we? Yeah, we don't all make the same mistakes. My mother, I'll tell a story about my mother, because that's safe because she's in England, so she can't hear. And she can't use YouTube or anything like that.
Not on Facebook.
Not on Facebook. No, she's not on Facebook. No. So anyway, she and my father retired, and they'd always lived in England, in London or the surrounding areas, and they'd always had a townhouse and a small garden and enjoyed life. So of course when they retired, they listened to the geriatrician's son who advised them about issues of accessibility and watching it. And I thought they'd buy a bungalow, so what did they do? They went and bought a large detached house in Wales with an acre plus of land in a little village where there was one shop that closed about 3 months after they moved in. So the nearest place to go and get your milk and eggs was over 10 miles away. And then unfortunately my father developed bone cancer and fell and fractured his leg, so he could no longer drive. So my mother had never driven. So there they were. So anyway, they managed for a couple of years there. My father died. And then my mother had to think about moving. So, fine, she'll listen now to a geriatrician son, won't she? We had all the discussions about what she needed, and then one day she phoned me and said, John, well, I listened to you, and I bought a condominium. Great, I thought. Except it's really a duplex, and it's the upstairs one.
There's no elevator.
No elevator. It has a wonderful view, though, John, of swans, and I own a dock.
Oh, no.
Mother, you don't have a boat. But it's so nice, John. I can feed the swans. When she walks down the stairs and walks along this very narrow, rickety little pathway and risks walking on this dock which sways. So, she survived that for about 15 years, and now she's finally, at the age of 90, moved into that bungalow. So it took her all of 25 years to listen to her geriatrician son. So she's now preparing for a retirement at 90. Next slide. We really don't want to be a burden. I think all of us, as we get older, we hope we're going to enjoy good health, but if we are going to have any ill health or any adverse event, we don't want to be a burden. So we have to plan. As I said, my mother between 65 to 90 was going upstairs or isolated, so she really did not plan to not be a problem. But she just couldn't imagine she was going to be a problem. That was her planning. Next slide. We want to maintain our health and independence. Next slide. So, what happens if you don't prepare? I think the answers are going to be obvious to everyone. Next slide. Increased probability of frailty and adverse outcomes. Now, what do we mean by frailty? We mean physical and mental frailty. Next slide. Social vulnerability. Living alone. Being isolated. Having limited income. Next slide. Presence of multiple chronic disease. Now, the presence of multiple chronic diseases, things like diabetes, hypertension, stroke, doesn't necessarily mean you are frail and disabled, but it definitely increases the likelihood. So by the time you have 3 chronic active diseases and you're over the age of 65, you have about a 60% chance of being what we call frail, which means you can't do the things you want to do. That's what frail means. Next slide. And what does frail mean in terms of your prognosis? Well, this was a group of individuals in Canada who were living in the community who were followed for 7+ years. And I just want to get across the message that many of these people were independent at the time of study. But as they were followed, things changed. Next slide. And those individuals who are well, what do we mean by well? Okay, category 1 well is someone who is completely independent in all activities, not requiring anyone to do anything for them, also actively exercises every day. They do exist. Number 2, in terms of well, is someone like the rest of us who intends to exercise, who has equipment probably in the basement that gathers dust, and occasionally they exercise, maybe once or twice a week. Category 3 is someone who never exercises but is still independent. Category 4 is a group of people who are vulnerable. And what's happening here is they're still independent, but they started to change their lifestyle. Maybe they haven't gone to Florida because they don't feel up to traveling. Maybe they started to cut back on some of their social activities. Maybe they can no longer complete the round of golf. So they're starting to change their expectations and activity because something is slowing them up. Therefore, mildly frail are people who have some dependency. They have some need for help, particularly at things like bathing, dressing. Perhaps someone doing the shopping for them. So they would have challenges in using public transportation, or maybe they can't drive the car themselves. Moderately to severely frail are people who are starting to need increasing help in their daily activities, maybe challenged in walking, maybe need to have assistance in getting to the bathroom, needing assistance in things like toileting, etc. Things we don't want to happen to us, but can happen to a significant, small but significant minority. Next slide. So the point I want to make is those individuals over time, if you start looking at survival rate or rate to going into an institution, those are in the well, not surprisingly, do a lot better. So the people in any one of the 1 to 3 at 7 years post entering that study were still mainly living in the community, over 80% of them, and were alive, even though their age of entry in the study was in excess of 70 years. However, when one looked at the frail group, the lower group, 5, 6, and 7, the average life expectancy was just under 4 years. And more than half of them were in long-term care within 5 years. So one of the reasons why you want to age well is to avoid frailty. Because frailty in itself, that dependency, is a measure somehow of your future health and future life expectancy. Next slide. And those individuals, unfortunately, are going to use more healthcare resources and community services than many other older adults who haven't become frail. Next slide. Disproportionate use of hospitals, disproportionate use of family physician, disproportionate use of things like long-term care. They're more likely to be on more medications, so therefore greater cost in terms of the Ontario Drug Benefit Plan. Next slide. But the key message is there are a minority of seniors, of older adults, that actually 60% of all the use of hospitals and healthcare services by people over the age of 65 is by only 10%. 90% use 40% or less, which is the same as any other age group. So the majority of older adults age well. It's this subset of frail, vulnerable individuals who unfortunately are more challenged. And that's what we want to avoid. And it is potentially reversible, at least in the earlier stages. And I'll talk about some of the reversible strategies you can consider. Next slide. Because one of the problems actually is if you have these multiple chronic diseases, you're more likely, if you're frail, to spend more time in the emergency department, to have more frequent hospitalizations, and to spend longer in hospital. Next slide. You're more likely to be on multiple medications. In 1986, when I first came to Canada, at that time, the average number of prescribed medications of individuals 65 and older was less than 3. It now exceeds 5. And in fact, many individuals, the ones I see in hospital or clinic, are on 10 or more medications, prescribed medications. Once you're on 8 or more prescribed medications, the risk of adverse effects from those medications is almost 100%. In other words, inevitable. Next slide. And just to remind you, I'm talking about prescribed medications. We need to add another 3 across-the-counter medications that people buy. Frail, vulnerable individuals lose is a loss of control over their housing options. Next slide. They're more likely, unfortunately, to go into situations like long-term care, retirement home if they have sufficient funding. Next slide. And unfortunately, many of our hospitals have a number of people who they term ALC. These are individuals they say need alternate living care arrangements. So they don't belong in hospital, but there isn't an alternative at this point in time. This proportion, it's rapidly reaching nearly 20% of hospital bed days which are being used by people who are termed ALC, but they haven't got an alternative. Next slide. So, let's move to the other side. How can you avoid becoming frail? Next slide. Which would you rather be? The gentleman, who's a rather dapper gentleman, who carries a cane, rather just for occasional use. He, in fact, just prone to swing it. He walks along street, no cares, a little bit bent over, maybe a little bit of osteoporosis. Or do you want to be the gentleman on the bottom, leaning on a care provider who's clearly living within a restricted environment, probably living in a retirement home, and is just managing a short walk along the garden? It's not hard to say who's the frail one, is it? Next slide. Or do you want to be the lady dressed up in her glad rags, hair done, with a boyfriend, or sitting at home mid-morning, curtains still drawn, unchanged, multiple medications in her hand because she's depressed? Next slide. The young grandma reading to her grandchild, or the frail individual in nursing home tended to again by her granddaughter? Next slide. Or finally, the lady who's receiving physiotherapy for her stroke, or the lady who's about to go and play basketball? Next slide. So we know which one we want to be out of each of those pair sets. So how are the things we can influence it? Well, there's evidence that diet has an impact, and I'm sorry you all just ate the wrong food. Because the evidence is, much as we hate it, us meat eaters, that we need to reduce our amount of meat, increase our vegetables, tofu, hate the stuff, and beans. So we do need to modify our diet in terms of the content of it. We can still have some meat, we just need to watch the amounts and keep it to lean meats. Next slide. We should try and engage in at least low intensity activity. It's suggested that actually most of the loss of muscle and gain of fat that we see with people as they pass their middle age is actually due to inactivity or poor diet. It's not due to aging. At the extremes of age, we can all build up muscle. So if you lose it and use it, you can regain it. But 1 day of bed rest loses 1% of muscle. It takes 6 to 14 days of exercise to regain that 1%. So if you go into hospital for a week and are immobilized, it's going to take you something like 2 to 3 months of active exercise to regain that muscle.